Good day, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. It's my pleasure to welcome you today to our CAQH Core Open Mic. Before we begin, I would like to mention some logistical items. You can download a copy of today's presentation from the caqh.org website. To do so, navigate to the Core pull-down menu at the top of the caqh.org welcome screen and select the Core Education Events page. A link to the PDF version of the presentation can be found under the listing for today's webinar. On this slide, you can see a screenshot of the attendee GoToWebinar dashboard. You should see something that looks similar to this on the right side of your computer desktop. When joining today's session, it's possible you may have joined the audio portion of the webinar using your computer speakers by default. If possible, we would prefer you to join the webinar audio by telephone. To do this, please select the telephone audio button in the audio panel of your dashboard, and the dial-in information will be displayed. Make sure you enter your audio PIN, which is found under your dial-in information. We will save time at the end of today's program dedicated to responding to audience questions at the end of every segment. I'll describe that a little bit further in the next slide. You're encouraged to submit your questions at any time during this webinar by typing them into the questions panel on your dashboard. We do ask that when you submit your question, you identify the type of organization you're with so we can give you a more accurate response. We will also be taking audio questions from the audience over the telephone at the end of every segment of today's session. When we begin the audio portion of the segment, you may raise your hand using the hand raise tool found on your webinar dashboard. When it is your turn to ask a question, we will unmute your line and you can begin. Please hold off using the hand raise tool until you're prompted to do so at the appropriate time of every segment. Once again, in order for your line to be unmuted, you must enter your audio PIN on your telephone keyboard. Today, we look forward to hearing from you and answering your questions. We'll start off with a general CAQH core update, and then we will divide up by topic, as you see here on the agenda. For every topic, we will spend a minute or two on overview, and then we'll take your online questions, and after that, we'll open up the mic for live questions. We will do that for EFT and ERA operating rules and maintenance. Then we'll do the exact same thing covering Phase 4 CAQH core operating rules, then voluntary certification, and finally we'll leave some time for general questions to make sure that we answer all of your questions. Feel free to ask your online questions on any topic at any point during the webinar, but in order to keep the conversation somewhat organized, we ask that when we open up the phone lines, you ask the question for that particular topic. In other words, ask your Phase 4 questions during the Phase 4 portion of the open mic. So let's get started with our first presentation by Core Director Denise Benning, who will give us a core update. Denise?
Great. Thank you, Jessica. Hello, everybody. Welcome to our friends also on the West Coast today, and also those of you dialing in from HIMSS in Las Vegas. Understand we have a few people that are getting on the phone, so welcome. We're going to have a little bit of an overview here at the beginning of our session today to talk about just in general CAQH, CAQH Core, and some of our initiatives and what we're going to be looking at in the future. So let's talk a little bit about our organization writ large, which is CAQH, which is the Council for Affordable Quality Healthcare. We are very fortunate in that we are nonprofit on both sides of the house, on both CAQH and CAQH Core. We're nonprofit, and we have a very unique status in the association community in this country in that we not only work on the regulatory side of healthcare, trying to streamline its business through administrative simplification, but we also follow through on that commitment to an admin simp by coming up with solutions or tools that the industry can actually use to implement these things to get better return on investment. So we are unique in that we are for industry by industry. Much of our work on both sides of the house is driven through our work groups, our subgroups, our task groups that are made up of participants of our organization, more than 140 stakeholders strong. And they have a very, very active and engaged involvement with what goes on with our organizations. So we have, on the solution side of the house, we have a number of tools that are available to industry to get over some of the humps that and challenges that we have in streamlining the business of healthcare. Those include CLB Smart, which speaks to coordination of benefits issues, Enroll Hub, which allows enrollment for electronic payments and remittance advices, CAQH ProView, which is a provider certification tool, Sanctions Track, which talks to multi-state information on healthcare provider licensure disciplinary actions across state lines. And then, of course, CAQH Index, our annual tracking of industry adoption of electronic administrative transactions. So we are a part of this in that we maximize business efficiency by developing and implementing federally mandated as well as voluntary operating rules. So we have our core mission and our core, we share this with our friends on the CAQH side, in that we both drive the creation and adoption of healthcare operating rules that support the underlying standards. We foster interoperability, and we try to align the administrative and the clinical sides so that everybody benefits, providers, payers, and consumers. So when it comes to operating rules, this is really our area of expertise. We were established in 2005 and actually produced operating rules before they were popular. We support a range of existing standards, existing HIPAA standards, to make electronic data transmissions more predictable, regardless of the technology or the vehicles that are being used to communicate them. We have an integrated model. We do rule development, we test, we certify, we track, and we conduct outreach. So we have the entire loop of implementation, from just a spark, an idea in someone's head, to actually educating the industry as to how it works. And we also have a fantastic core certification program. This is really the gold standard for the industry, for you and your trading partners to demonstrate conformance with the operating rules and their underlying standards. And you'll be hearing more about that from Matthew Albright later in our program. In terms of the ongoing maintenance, we have we work on code combinations, and we've been doing this for a number of years. We have not only compliance-based reviews, but we also have a market-based review. And if you go to our website, you can see here that all the information as to the changes that take place on a regular basis throughout the year are posted here. And it really is a way for the industry to become involved. These codes are very important because they really affect denial management and claims processing. And this is something that the industry has been involved with, but we'd obviously like to see more involvement in keeping up with these core combinations. Then we also have, under core certification, the HHS proposed program and core. And this is something that has been taking place last year. Actually, it was 2014. I keep thinking that we're still in 15. In 2014, the Department of Health and Human Services included core in a proposed rule that, under the Affordable Care Act, required health plans to demonstrate their conformance with underlying standards and operating rules in existence at that time. They used the core certification program excuse me, as a way to have health plans attest to their conformance with these standards and operating rules. And we're still waiting for them to finalize the rule. We understand that HHS is going to be issuing a voluntary, not a voluntary, but a new notice of proposed rulemaking sometime this year, so we're looking for that. So we have been actively involved in that. And of course, we have education events like this webinar. We do this free of charge for all of our events online. We have numbers of different types of calls. We provide all sorts of different topics, from open mics to phase 4 to certification. And we also offer, again, free of charge, implementation resources like planning and analysis guides, including gap analysis, as well as a slew of FAQs and other tools to help you to implement the operating rules so that you can maximize your return on investment. So how do we get there? As I said, we've been doing voluntary operating rules since before the Affordable Care Act, but we have a number of them already in place and have been adopted and they are now mandated requirements through HHS. In 2013, we had health plan eligibility and claim status transactions. In 2014, we added electronic funds transfer and remittance advice, and those are mandated. As I talked before, the ACA mandated HHS health plan certification is still pending. We're expecting a rule sometime this spring. And of course, we have our new phase 4 operating rules for a number of different standards: health claim equivalent encounter information, referral, certification, and authorization, enrollment, disenrollment in a health plan, premium payments. We do not yet have any operating rules for health claims attachments because HHS has not yet adopted a standard. And those have been approved for voluntary implementation. That was voted on by the core board back in September, and we are pending action on that by HHS. So here is our regulatory next steps. NCVHS is the National Committee on Vital and Health Statistics. They are a national advisory body to the Secretary of HHS, has been in existence for over 60 years. And we testified in front of their committee this past month, and the next step is for NCVHS to make a recommendation to the Secretary as to whether these rules should be adopted or not. So HHS will come out with a notice of proposed rulemaking, which normally has a public comment period of 60 days or more, through which people can make comments on what they're proposing. And then, of course, it usually takes around 2 years for the industry to implement any changes. So if HHS were to take that opportunity to mandate adoption, the industry would have some time during which CORE would provide them with implementation tools to get them to that point. But that's our current workload. Let's talk a little bit about future. One area of concentration for the core board is future vision. What will the healthcare system of tomorrow look like? What does CORE need as an organization to do to help the industry prepare? Being ever mindful of our mandate to produce operating rules for both HIPAA and ACA, for admin SIMP, for the existing fee-for-service environment, and consider the advent of other alternative payment methods. The board has agreed that our future focus should be on continuing support for existing fee-for-service operating rules, but to look at new payment models that are evolving. Of course, we're referring to value-based purchasing. Under our board's direction, we started last year to work on value-based purchasing in stages. In Q4 of 2015 into the beginning of this year, we conducted a study of what it would take for the industry to be successful with value-based purchasing. And we identified a number of potential operational areas for industry action. These include common data sets and terms, infrastructure rules to improve security and connectivity, and process rules to help improve workflow. Through the first half of this year, we'll be undertaking industry interviews with those experienced in value-based purchasing to confirm or add to these potential areas, assess a business case, partner with others in key areas, and make recommendations to industry. In Q3 of this year, we will undertake development of business cases for these identified areas, if appropriate, or recommendations for others to move forward. And in Q4, we'll focus on developing, supporting, and monitoring industry progress towards these areas, taking into consideration that those that hold the most return on investment and are strategic and organizational fits for all stakeholders. We're looking forward to engaging core participants in this value-based purchasing work as it progresses. That's my presentation for today, and now, Jessica, back to you. Thanks.
Thank you, Denise. Our next segment of the open mic focuses on EFT and ERA operating rules and maintenance. Senior Manager Bob Bowman will give a brief update on the topic. After that, we will pause for an Instapoll question, and then we will take your online questions, followed by opening up the lines and taking your live questions. So go ahead and start sending in your questions, and also start thinking about what live questions you might want to ask. Bob, let's begin our presentation.
Great, thank you, Jessica. As you can see on the next slide, there is a maintenance process in place for the Phase 3 rule set. So for those rules that require maintenance, particularly the CARC and RARC rule, as well as our data set rules for EFT and ERA enrollment, those rules have specific requirements that the data sets as well as the core code combinations are maintained on a periodic basis. Task groups have been established for both of those rule sets, for this rule set, to ensure that the industry is looking at kind of real-world data usage to ensure that through a complete review and analysis of the data and how the codes are used or how the data is used, through open and relevant discussions by the task group members, through straw polling and through final approvals, those rules are maintained, again, periodically throughout the year. For the CARCs and RARCs, it's 3 times per year because of a compliance-based review and a market-based review. And the EFT and ERA enrollment data sets are maintained and reviewed on an annual basis. So those 2 task groups, the code combinations as well as the enrollment data set task group, they will work with the industry, and as members of the industry are looking at that data on a periodic basis to ensure that they meet the business needs, both for explaining the reasons behind code, the reasons behind specific code denials or adjustments to a claim, as well as to ensure that the enrollment data sets are meeting the ever-changing business needs that are taking place for EFT and ERA enrollment. So just to let you know that those task groups are open to any core participating organization. So if you're interested in either one of those topics or working within one of those task groups, please reach out to us and let us know, and you can make sure that you're plugged in and be part of that process. With that, I think we'll have a polling question, and as well as we'll start opening up our questions for all the questions that we received through registration as well as through our online live questions. So Jessica and Drew?
Great, thank you, Bob. So this brings us to our first of 3 polling questions that we have for today. And I'll read the question and then I'll open the poll for everyone to respond. This question is, what benefits has your organization experienced from the past 3 years of CAQH core code combinations and core defined business scenarios implementation? So I will open the poll and we will pause briefly for everyone to answer. And this is check all that apply, so there might be more than one. And we'll pause for about 20 seconds. Feel free to answer right on your computer desktop. We'll wait for 5 more seconds, and I will then share the results. Okay, I will close the poll and share the results. So 68%, the largest percentage, said that they were unaware of measurable benefits and experience. And you can see the message at the bottom of the screen here that we would like to hear from you. And reach out to us, of course, at core@caqh.org, and our staff will work with you, and hopefully that you find these education sessions as well as those in the future beneficial. This is certainly why we have them. Bob or Omni, do you have any remarks that you'd like to share based on these results?
Sure, thanks, Drew. Yeah, we also wanted to note that we did see that about 26% of you saw some reductions in unnecessary provider follow-up, which is exactly one of the goals of the code combination, is to make sure that providers are getting all the information they need so that you can essentially process your claims more quickly and cleanly and not have to do as much follow-up and really speed up your revenue cycle. So that's what we're going for, and we're glad that some of you are seeing those benefits. And again, for those of you who are unsure what benefits you've experienced or maybe how to quantify them, do reach out to us. We're happy to talk with you and learn more about your implementation, see if there's any resources we can provide you. So just go ahead and give us an email to core@caqh.org.
Thanks so much, Omni. Let's take some online questions. The first question, I believe, is for Omni. And the question is, are there any plans to expand the scope of the CAQH code rules beyond the 4 business scenarios?
Great question. Thank you, Jessica. So yes, the core code combinations in the Core 360 rule currently addresses 4 business scenarios. So we have 4 core defined business scenarios established. There is interest in amongst the core participants in the task group that maintains the rule in expanding those business scenarios. So we conduct an annual survey each year where we collect industry suggestions on changes to the code combinations based really on evolving and industry business needs. And we did receive some potential new scenarios last year. However, through our kind of rigorous scrubbing process, they weren't approved to be added. But we will again be collecting additional potential new scenarios. That's kind of an ongoing goal for the Core 360 rule, just to make sure we are addressing all of the business needs out there.
Thanks so much, Omni. Here is another question, and I'm not sure if it's for Omni or for Bob, but the question is, why isn't the list of approved CAQH and RUG code combinations more stable? Why does it change so much and so often?
I can take the first stab at this, Omni, and then feel free to jump in. I think that there's kind of a couple things going on here with the CAQH and the RUG code sets. Initially, I think, even just a couple of years ago, there was quite a bit of resistance from providers to adopt the 835, and that's because the CAQH and the RUG code list didn't provide the level of granularity or detail that providers needed to help them understand exactly why a health plan was adjudicating a particular claim or a claim line in a particular way. They couldn't understand exactly what the health plan was doing. So providers relied heavily on their proprietary remittance advice from the health plans also provide. So if health plans are providing both a proprietary paper remittance advice as well as an 835, but the provider has more detail on the proprietary paper remittance advice, providers didn't want to give that up. And so they relied on those and didn't use the 835. So the CAQH and RUG committees made quite a few changes to the list, and they're trying to, and it's a maintenance process. They go through and update the code sets 3 times per year to make sure that the codes are meeting the business needs, both of the providers as well as the health plans, to ensure that, the better communication of those reasons are relayed to the provider. So those code sets are updated frequently, 3 times per year. And so that initiates a compliance-based review at CAQH to make sure that if there are any adjustments to the definitions, either new codes, the definitions may change, or some codes are removed from those different types of adjustments that occur, we go through a process at CAQH where the task group reviews those types of adjustments and makes adjustments to the core code combinations and that are part of the 4 business scenarios. So you have this kind of a cyclical process where to ensure that providers adopt the 835 to make sure they get the benefits of using electronic posting and automatic posting and the reductions of reaching out and using a provider portal, which again, remember, many providers bill many health plans, and if they have to go to a provider portal and make this a manual process, it's very costly for providers. So if they can automate this process as much as possible, by not relying on a proprietary paper remittance advice, getting rid of the paper, getting rid of the manual downloads, and can auto post with an 835 and an EFT, that simplifies the provider process quite a bit, and also reduces the overhead of health plans to make sure they have to maintain 2 different remittance advice, one being proprietary, and then one that is actually part of the 835 that they're required to support. So I know that might be a long-winded answer, but it is a cyclical process to ensure the providers get all the benefits they possibly can from electronic transactions. They can automate their billing process and their AR process.
Thanks so much, Bob. So Bob, stay on the line because the next question is also for you. It's an enforcement question. The question is, we have a payer that has implemented EFTs but not ERAs. What can we do so this payer will implement ERA processing? Do you have any helpful tips?
That's a great question. And one thing that I guess I would advocate is that all HIPAA-covered health plans must support both the HIPAA-covered transactions as well as the mandated operating rules associated with them. So a health plan must be able to generate an 835 if a HIPAA-covered entity requests it. So if, as a provider requesting an 835 from a health plan, that health plan must be able to support that transaction and deliver the 835 to the provider according to the operating rules as required by regulation and by law. So there are a couple of options that a provider would have in that scenario. They can definitely reach out to the health plan and ensure that the health plan is aware of these requirements and then build towards the process of receiving the 835, as well as there is a complaint process through CMS where a HIPAA-covered entity in this particular scenario would be the provider can file a complaint against the health plan, and CMS will notify the health plan of the basic requirements and then work with that health plan to ensure that they're in compliance. In short order, they do have requirements. It is the law that health plans be able to generate the 835 upon request. So there is that complaint process. It has been used in the past, and it's been very effective in getting health plans to move towards the automated process to ensure that providers receive all the benefits as required and as expected under the law. So, and I'm not sure if we had several other core staff members on the line as well. I don't know if anyone has anything else to add to that response.
Thank you for that answer, Bob. So let's open up the lines. And just as a reminder, if you do have a question, remember to raise your hand using the hand raise tool found on your webinar dashboard. So let's open up the line. So I see Melissa with an open raised hand. Melissa, do you have a question?
No.
Go ahead.
No, I don't have a question.
Oh, okay. Sorry about that, Melissa. I see that Callan Mitchell has his hand raised. Callan?
Yes.
What's your question?
You know, I've attended a lot of these meetings, and it keeps coming up that these transactions are mandated. The EFT and the 835, 270 and 271, your eligibility claim status. The reality is they're just mandated in name only. If there's no penalty that health plans have to pay, then it's basically not going to happen. I mean, your own statistics show that more people get paper remittances than they get electronic remittances. And it's not that the providers can't handle electronic remittances, because that's all they get from Medicare and Medicaid. So until this certification happens, which seems like around spring every year, we hear that there's going to be mandated certification for health plans, but it gets put off another year. I mean, the first time I heard that was in 2014. So when is it going to actually happen that there's some teeth to these mandates?
Okay. This is Denise Benning. I'm core director, and I'd be happy to answer at least part of your question. There are repercussions if a health plan is not conducting the transaction, and in fact, if any HIPAA-covered entity is not conducting the transaction as they should. That goes through the CMS enforcement area. But the issue with that, and again, having been the head of this, I can speak to it, is there is a reluctance on providers' parts, quite frankly, to issue any kind of complaints against health plans because they're afraid of repercussions. Even though you can put in a complaint anonymously, but it's very difficult because then the follow-up is, well, you know, we have to have the circumstances under which this transgression occurred. That being said, There is a process. There are fines to be levied if you're found to be out of compliance. If after their mitigation program you still refuse to conduct a transaction that has been mandated. In the 10 years or so, actually probably more than that, but in the 10 years that I was involved with it, I don't think we ever levied a fine for a HIPAA violation for transactions and for standards and operating rules. And that was because CMS did a very good job of trying to bring the parties together. They were not punitive in nature. They were more, let's get everybody to get on board and do the transactions correctly. So I know there is frustration out there. In terms of when things are going to take place, that's something that is really unpredictable. The normal regulatory timeline for these things is a minimum of 18 months just to go from writing a proposed rule to when it actually becomes effective. And then the HIPAA mandate, if it's a new standard, it has to be at least 2 years past that to give the industry time to implement it and change their systems over. So it's a long process. However, it's transparent and it's inclusive, and it's the best that government can do at this point. That's all I'll say. It's the best that government can do at this point.
Thank you, Denise. We're going to move on to our next segment now, which focuses on the Phase 4 CAQH core operating rules. Senior Manager Erin Weber will give a brief update of the topic, and just to remind you one more time, after this brief update, we'll follow the same pattern as before. So we'll pause for an Instapoll question, then we'll take your online questions, and after that, we'll open up the lines. Erin, please begin when you're ready.
Great, thanks, Jessica. As many of you are probably aware, in September of 2015, the Phase 4 CAQH core operating rules were approved for voluntary implementation. There are 5 rules in this rule set addressing 4 different HIPAA transactions, including claims, prior authorization, enrollment, disenrollment, and premium payment. There are many key components to these operating rules which are primarily infrastructure in nature. There is a connectivity rule that offers one common method of connectivity through a safe harbor among entities transmitting data electronically. The rules include a set of infrastructure requirements for each of these transactions, similar to the infrastructure requirements you may be familiar with in past core phases, such as system availability, acknowledgments, response time requirements, companion guide template, etc. There are many benefits to implementing these operating rules, including increased and simplified security and connectivity, improved customer service, improved revenue cycle functionality, reduced manual intervention. The status of these rules now is that they are available for voluntary implementation, and you can begin implementing now. We have a number of tools available to do so. As Denise mentioned, CAQH Core did testify at a recent NCVHS hearing on the status of these rules, and NCVHS will determine whether it's appropriate to make a recommendation to HHS regarding the adoption of these operating rules to fulfill the 3rd set of the ACA mandated operating rules. So with that, I think I will turn it over to Drew to do a poll.
Great, thank you so much, Erin. And this brings us to our second poll question of the webinar. And just like last time, I will read it and then launch the poll for everyone to respond. And this question asks, which stages of implementation of the Phase 4 CAQH core operating rules are you planning to complete in 2016? And again, this is one with many possible answers, so please check all that apply. And we'll pause for roughly 20 seconds or so. We'll pause for about 5 more seconds. A few more seconds and I will share the results. Closing the poll, and I'll share the results here. So 50% of you said you're conducting internal education and awareness. That's good for Jessica and I to know, as we are the education and outreach team. So we're happy to help, of course, in that. 48% said analysis and planning, systems design. 25% indicated systems implementation and integration, as well as testing. 13% said deployment or maintenance. And then 25% of you said not applicable, as you are not planning to implement in 2016. So Bob or Aaron, what do you make of these results, or any comments?
I'm very excited by these results, Drew. I think we have to keep in mind too, the not applicable may be that some of these organizations responding are not typically organizations that implement the rules. So we have a number of associations and other folks on the line who are doing education and awareness amongst their own constituents. So I'm very excited. We're going to have a lot for you to help with these steps over the year, particularly around analysis and planning rolling out in the next few months. So keep your eyes peeled, and as you mentioned, we'll have plenty of education sessions to assist.
Thanks so much, Aaron. So I'm going to take over now and start taking some of your online questions. The first question is for Bob. Bob, the question is, what is the connectivity safe harbor?
Oh, that's a great question, and one that's really important, because the connectivity safe harbor is basically a requirement of the rules that ensures that the entire industry is building a network in which the transactions can flow. So it's a requirement upon either clients or servers, or we would say a submitter of a transaction and receiver, a provider in a health plan or a clearinghouse, for example, can receive the transaction, conduct the transaction, and support all of the connectivity in a way that's uniform from one entity to the other. And this ensures a basic infrastructure is built for the conduct of the transaction. Maybe more distinctly, it allows a provider to choose, again, vendor agnostic, how they wish to send and conduct the transaction to the health plan, and the health plan would receive that transaction. It does not mean that the health plan has to disconnect any of its current connections. So if you use a VPN, if you use 10 other different ways of connection with all of your trading partners between your direct connect providers, your clearinghouses, your TPAs, you have all kinds of connectivity in place today. You do not have to unplug those. You do not have to move those entities to this one way. But it is a way of supporting one way of conducting the transactions that anyone that wishes to conduct can do so in that way. So you'll see, and we've have many health plans have seen this through time, that once they've implemented this one pathway, more and more individual trading partners want to come through that pathway, because it's a kind of a guaranteed way to ensure that the transactions come in, there's specific acknowledgments, there's specific turnaround times. The roles and responsibilities of the trading partners are very clearly defined because this pathway has very specific requirements around it. Whereas many of your other connections don't have those types of trading partner agreements around them that are specific as the requirements of the operating rules. So again, it allows that one pathway, and if every health plan and every clearinghouse and all the different provider software, practice management software supporting that one way, at a minimum, it really allows for a network to be built up.
Thanks so much, Bob. I've got another question for you, Bob. And the question is, can a HIPAA-covered entity or its agents still use connections that are not compliant with the Phase 4 CAQH Core 470 connectivity rule?
Yep, definitely. Again, you don't have to unplug anything that you already have in place. You can continue to maintain those ad infinitum as long as you need to, as long as your trading partners wish to conduct the transactions in that proprietary way. It does mean that you are supporting a proprietary connection method. And it's probably only good for that one trading partner, and the next one's only good for that one trading partner. And you'll have to maintain multiple connections, or you may have outsourced that to a clearinghouse who is then charging you to maintain all of those proprietary connections for you. But that method between the safe harbor of the core connectivity method and any method that you wish to support after that, again, it's going to be a business decision on how long or how often, how many of those proprietary connections you're going to maintain. But the rules do not preclude you from doing that.
Thank you, Bob. We've got one more online question for Aaron. The question is, what resources are available to assist my organization with implementation of the Phase 4 operating rules?
Great question, Jessica. On the CAQH Core website, you can go directly to the left-hand menu bar to go to the Education and Implementation Resource Center. There we have a number of tools specific to Phase 4 and that apply across all the operating rules. For Phase 4 right now, we have the Analysis and Planning Guide, which contains a number of unique tools within it to help you get started. A gap analysis tool, which lists all of the Phase 4 requirements, systems of readiness assessment. So that would be the top tool I would say to use first. Additionally, we did just relaunch our FAQs on a web-based format. We also, with that relaunch, added more than 100 Phase 4 FAQs. So if you have specific questions about the requirements within the rules, that would be the first place to look. And those rules are all now web-based and searchable, so much easier to use.
Thank you, Erin. I'm going to take this opportunity to open up the line. If you have a live question you would like to ask, please click the raise hand tool button. So I see that Michael Garrett has a question. Michael, go ahead.
Yes, our question has to do with, I'm going to call them fiscal intermediaries. These are entities that payers contract with to fulfill their compliance with EFT, apparently or allegedly because they lack the resources to do or infrastructure to do it themselves. In doing so, the fiscal intermediary then charges the payer a certain percentage for, and this is a distinction they make, not additional charges, but rather additional services which they claim that they're providing. I think you're probably familiar with the situation, but so my question has to do with, in that situation where we do not want to be paying those fees to the fiscal intermediary, is the recourse back with the payer who is not complying on their own with the EFT transaction, or is there any recourse with the actual fiscal intermediary who's charging what really seem to be like additional charges rather than fees for services?
Michael, that's I think a very great question, and one that's very important, especially for providers, because providers are the ones usually at the short end of that payment who are having to, or being assessed those fees, a certain percentage of that payment. And I can give you my perspective on this particular scenario, but the fees that are being deducted from that payment, because it's not an EFT payment, it's usually a credit card or a virtual card payment that the provider is receiving, because of that fiscal intermediary, some sort of perhaps a TPA or some other entity rather than the health plan where the health plans perhaps outsource the payment processing for those types of bills or charges. The ACA and the regulations that adopted the EFT transaction as a HIPAA adopted transaction. Since the EFT is now a HIPAA transaction, all health plans must support that transaction. Just like as we heard earlier in the call, the 835 is a HIPAA adopted transaction, all health plans must be able to conduct it. The same holds true for the EFT transaction. So the health plan must be able to support an EFT transaction if the health care provider requests to receive an EFT. There's no out. They can't get out of that requirement and say that they only outsource virtual card payments. The EFT is a required HIPAA transaction, and health plans must be able to support that transaction. So I think your question perhaps is the recourse is back to the health plan, where providers can make that request. And if the health plan is not in compliance or not in unable to support at the time of the request, then as Denise mentioned earlier, there's lots of ways that providers can make sure they kind of ring the clarion bell here and make sure that the health plans are kind of get in line and make sure that they can support those direct EFT payments to the provider, since it is a healthcare transaction under HIPAA. And I'm not sure if Denise or anyone else on the call would like to add to that or not, but I think it's a very great question. I think it's a very impactful to providers, that they are losing out on those particular fees that are being assessed through the virtual card payments. So it's a very important question.
Thank you, Bob. Thank you for your answer, and hopefully, I think that was a great answer. We do have to move on to our next segment, which focuses on voluntary course certification. We'll have Senior Manager Matthew Albright give us a brief update on the topic, and you know what happens next, same as before. Insta-poll question, then we'll take your online questions, and please start, you can start putting them in right now, and then we'll open up the lines. So Matthew, take it away.
Thank you, Jessica, and thank you all for attending today. If I could just touch on Michael's question and Bob's excellent answer with regard to those extra fees that might be charged, whether it's for ACH claim payments or claim payments through virtual cards. We know that the AMA and NACHA and other groups are really pounding CMS to clarify the rules around this. So again, Denise referred to the complaint system that CMS has, where a provider, or really any entity, can file a complaint against a health plan or any entity involved with the functions of these transactions. I would definitely suggest that you use that tool to file a complaint. And again, this would kind of put a little bit of pressure on CMS that they're getting from other quarters to clarify if there's any regulatory way, any legal way that these entities who seem to be charging exorbitant fees for what accounts to, doctors getting paid, if there's any way that they can pull that back. So I would just suggest that tool again. Now, voluntary core certification. As a program, voluntary core certification is really the gold standard in how a certification program should be developed and administered. As many of you know, certification programs writ large are available in every industry sector throughout the U.S. and world economy and serve as a way to demonstrate that entities or products are meeting the rules and standards of that given industry. Now, voluntary core certification works the same way, but what makes core certification unique are the multiple parties involved in the development and execution of the program. This slide outlines elements that make up a kind of checks and balances that make the voluntary core certification program unique. It's a kind of three-legged stool. The first leg of the stool are the actual requirements that are necessary for an entity to demonstrate conformance with the operating rules, the actual test questions, if you will. And these are developed by industry representatives through a CAQH core subgroup. Those requirements, those test questions, are then put through the same thorough review and voting process that the core operating rules go through and that Denise and Aaron and others talked about. That is, they are voted on by entities that actually conduct the transactions. So this is industry deciding for industry what conformance actually means. Second, a third-party testing vendor. That would be the second leg of the stool. And this is separate from the industry representatives that develop the test and separate from CAQH core. That third-party testing vendor is used to conduct the actual testing. And lastly, the last leg of the stool is CAQH core that administers the program. And this includes authorizing that third-party testing vendor or vendors and giving a thorough review of the application and testing documents before awarding the seal. So a balance of power and some systems of redundancy create a solid certification program. And at this time, over 250 certifications have been awarded to government and commercial health plans, clearinghouses, provider and health plan facing vendors, and software products and services. And one last thing, Aaron and Bob talked about the Phase 4 operating rules. We expect voluntary core certification will be available for those Phase 4 rules by the middle of summer of this year. And with that, I'll turn it back over to Drew for another polling question.
Great. Thank you very much, Matthew. And so upon registration, we ask this question to those that register. And the question is, does your organization plan to pursue voluntary core certification in 2016? And you can see here that 120 responses, so 120 people registered for this webinar. Of those 120, 30 registered that, yes, they were planning to pursue, and 51% said that they were not sure. So a large number indicated they were not sure. 16 said no, 8 said that they were already certified, 8 said that they need more information, and 7 said they are not applicable. And on the pie chart, you can see the percentages of the total. And so the reason we are showing the registration question results is because it piggybacks off of our third and final polling question. And I'll read it to you like last time, and then I'll launch the poll for you all to respond. And it says, in your organization's experience, what are the barriers to pursuing voluntary core certification at this time? A little bit related, but I will launch the poll. Oh, sorry. I'll launch the poll, and we will pause briefly for everyone to respond. So again, in your organization's experience, what are the barriers to pursuing voluntary core certification at this time?
And select all that apply.
We'll pause for about 10 more seconds. And Matthew, get ready. I'm going to have you comment on these results.
Sounds good.
Take about 3 more seconds, and we'll share the results. All right. I will close and share what we've all learned. So interestingly, 74% said lack of resources, and this could be human, financial, time, or otherwise. And then 53% said voluntary core certification is not federally mandated, whereas 28% said our systems have not been remediated to meet CAQH core operating rules, 23% lack of management support or prioritization, and then 9% just said lack of understanding. And we'll, of course, be working very hard for that 9% to help them understand. But Matthew, what do these results say to you?
Well, I think that 9%, 10%, if only 10% see an obstacle of lack of understanding, then kudos to you and Jessica, Drew, because I think that says a lot for how we've been communicating out core certification and what needs to happen. So if you join this with your webinar survey, where about 50% said they were unsure that are attending, we can see that maybe of those 50%, here's some of their concerns or some of the obstacles, why they're saying that they're not sure why if they're going to do it. And I guess what I'd say, especially with that first one, with lack of resources, I know that a lot of health plans registered for this, so I imagine a lot of that 74% are saying, look, we got a lot on our plate as a health plan. We talked about value-based purchasing. There's a lot going on in healthcare, and that maybe a non-federally mandated process is not necessary. And I guess what I would say to that group is, you know, look to your vendors and look to your clearinghouses. Look to the entities that are helping you conduct those transactions. So if it feels like your resources are stretched this year and you can't do it this year, start asking your vendors, start asking the other, your subcontractors and contractors to whom you outsource some of these functions. Ask them whether they're core certified, or, you know, even back up, ask them whether they're meeting the CAQH core operating rules, because those are federally mandated, and then really turn around and ask them to give evidence of it by getting core certified. And you'll find that if in 6 months, a year, 2 years, you're ready to get core certified, that core certification is going to take a lot less of your resources if you've already done the homework of reaching out to your vendors, reaching out to any of the entities to whom you outsource to, and making sure they're core certified. So I guess that's my commentary on this, and I'll hand it back to you, Drew.
Great, and I'll hand it off to Jessica.
Thanks so much, Matthew and Drew. So let's begin with our online questions. Matthew, the question is, why is testing required for voluntary core certification?
Good question. I really like this question, actually. So we mentioned that core certification is set up so that the conformance requirements are developed by an industry task group, and then a third-party testing vendor develops the actual certification testing. And of course, in order to be core certified, organizations have to go to that third-party testing vendor to take the actual certification test. And, you know, we've seen over the past few years that entities that are required to implement standards and operating rules often have completely different ideas of what it means to be compliant with those rules. And they may adopt diverse or inconsistent approaches to testing adopted standards and operating rules. So although core certification has not been, as of yet, mandated by the federal government, I think we as an industry still need the ability to point to a specific standard set of documents that we can say demonstrate conformance with the operating rules and standards. And core certification, with that core certification testing element, provides that. You know, NCVHS, WEDI, and others, they've all pointed out that an inconsistent approach to testing results in industry-wide difficulty in implementing standards and operating rules, and for some entities, not implementing the adopted standards or operating rules at all. So this in turn, of course, delays the kind of network effect we need for administrative simplification to have a large impact on that clerical burden cost to patients that we're aiming for, cost to patients as well as healthcare providers and health plans. So again, if you're a provider, if you're a health plan, certification testing is a good way to make sure that your business partners are conformant with the rules and are applying the best business practices for efficient use of the standard transactions. You know, it's the difference between, on the one hand, your contractor saying that they are following the rules, and on the other hand, them producing a document that says that they've taken a test that proves that they're actually following the rules. It's like making sure your taxi driver has a driver's license. So again, ask your vendors and clearinghouses whether they've got that documentation that shows that they're conformant. So I hope that answers the question.
Thank you, Matthew. I've got a question coming in for Bob. And the question is, our organization does not currently conduct 276, 277 transactions. In order to become Core 1 through 3 certified, do we need to implement a 276, 277 transaction?
Jessica, I can't tell if they're what type of entity or organization this is, because the answer might vary a little bit. But if you are a clearinghouse or a software vendor, practice management software vendor that has a product that's perhaps provider-facing, you're not required to support the 276 or 277. But if you are a health plan, since this is a HIPAA-covered transaction, that health plans are required to support that transaction. So for health plans, you would be required to do that before you can, or be required to support the 276, 277 along with the appropriate operating rules before you can become Phase 2 certified or Phase 3, since the phases build one upon the other. But if you're a clearinghouse or software vendor, there you have the business option to support that transaction or not, and how you sell or market that product or service to your healthcare provider clientele. There's some variances and variability. So we do have some software vendors and some clearinghouses have not completed certification for that particular transaction, but still have the seal for Phase 2 or for Phase 3 or Phase 1 for that matter, because they don't conduct the claim status transaction. So it's going to be dependent upon your stakeholder type and the requirements for the transaction and the operating rule.
Thank you, Bob. We've got another online question coming in from Matthew. And the question is, on the expected HHS certification rule, will these new rules that go through the normal comment and adoption process and time frame?
Good question. And I would say yes, it looks as though they're proposing that a new NPRM, and they're expecting it to come out in April. And so because they're proposing it as a new NPRM, then we'll see the 60-day or perhaps more, 60, maybe 90 days for comments, and then they will come out with a final rule based on the comments they get. So we can expect the full rule-making scenario according to the usual timelines with this one. As people have noticed, we've already blown through the deadline that the ACA outlines for this, and so I think they're going to just settle back and go through the regulatory patterns here. And it's certainly not going to be an interim final rule with comments, so it doesn't look like it's on the fast track. And I saw there was another question about what this expected proposed rule would do, especially in light of the fact that we've already seen a proposed rule. And I'm just going to read what the statement says in the Unified Regulatory Agenda. And it said, this second proposed rule would revise the initial proposed provisions in response to public feedback received through the rulemaking process. So that's from them, and what that means exactly, we'll leave it to you all to try and figure out. And I'll give it back to you, Jessica.
Thank you, Matthew. And I see that we have one live question that's come in. So Michael, please ask your question.
Yeah, I'd like to go back to the question in regards to health plans that send us notification that they're, one, either not ready for EFT, or two, they're not ready for ERA, or three, you have to be contracted provider in order to receive both or one of the other. The regulations state that as a HIPAA-related service that they have to comply to the rules and regulations, but yet these are the type of responses that we get. Again, would the course of action be to notify CAQH and file a complaint via that way? I mean, what is our proper course of action?
Can they require contract?
Yeah.
So I can take that. This is Matthew. I can take that, and I'll tell you, there's probably two avenues. Certainly, if there is if the payer that you're dealing with, the health plan that you're dealing with, is a core certified health plan, specifically core certified in phase 3, then you can use the enforcement process with that we have with CAQH Core to basically make a complaint that says that this core certified entity is not compliant with the CAQH Core operating rules. If that is not the case, or even if it is the case, again, I would strongly say you utilize that complaint process with CMS. And if you just Google HIPAA Administrative Simplification CMS Enforcement, then you'll see that probably near the top will be this window, this online form that you can fill out and submit it. And I suggest you do that because again, I think that this question is being pushed on. Certainly, the added penalty, the added fees are being pushed on, but also we are seeing that CMS it looks like it's boosting up its enforcement environment. So they've started a whole new division just on administrative simplification enforcement, which means there's a whole division looking at those complaints coming in. And certainly, you know, inside baseball, we've seen a number of letters shot out from that enforcement division, and so it looks like they're serious about the EFT and the ERA stuff as well. They've got an audit capability that the Affordable Care Act requires them to set up, so we should be seeing evidence of that pretty soon. In other words, I would make CMS very aware of what's going on, and at the very least, I think what you can expect from CMS is a call back and a walkthrough about what their regulations say and what your situation, if it's conflicting with the regulations or not. Again, I think it looks like you have evidence that there is, but I think it's worth hearing from CMS what the extent of that is and what they could possibly do for it.
This is Denise Benning. I just want to add to what Matthew mentioned about CMS enforcement. What you're looking for is the CMS ASET, A-S-E-T system. It's an online system where you can plug in your information, and then you'll receive an acknowledgement that your issue or concern has been received, and then they have a specified process through which they will follow up with you.
Well, thank you so much, and it looks like we are out of time for today. I'd like to thank our speakers and also all of you for joining us and asking your questions. For those of you during registration who said they were unsure about voluntary core certification, I encourage you to join us on March 9th for our Core Basics of Certification webinar. And we also have another webinar on March 22nd focused on the Phase 4 CAQH Core Operating Rules. Besides that, if you are in Vegas at HIMSS, CAQH does have a booth, and there are some core staff there, so come for a visit and ask your questions and get some resources. And don't forget to answer the questions at the end of this webinar, and a recording of the session will be available in about a day. Thank you so much for joining us. Bye-bye.